with our respectable and well-known speaker, Professor Dr. Adel Hussein. Hello, Dr. Adel.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Dr. Adel, he's a consultant of adult critical care medicine in King Abdullah Medical City, Makkah, Saudi Arabia, and he's a former assistant professor of critical care medicine in Faculty of Medicine, Cairo University. Dr. Adel Hussein, he's the director of critical care administration and the chairman of the critical care committee in King Abdullah Medical City. And he's a director of RTP and FTP. The lecture today is about the acute pulmonary embolism guidelines. The floor is yours now, Dr. Adel. تفضل.
Thank you very much, Dr. Wissam, for your nice introduction. In the beginning, Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen wa salatu wa salam ala ashraf khalqi Allah al-mursalin Sayyidina Muhammad wa ala alihi wa sahbihi wa sallam taslima kathira. صلى الله تبارك وتعالى في البداية أن ينفع بما قدم وسنقدمه الليلة وأن يجعله يا رب في موازين الحسنات وأن يجعل هذا الوقت خالصا لوجهه الكريم. Second, I have to thank the panelists with us tonight for their valuable time. My appreciation for Professor Saad Mahdi for his dedication for the third year, almost non-stop, even during the COVID pandemic, for his mega learning. I ask Allah subhanahu wa ta'ala to reward him and to make this in his good deeds. Moreover, I have to thank him and the panelists to give me the opportunity tonight to be with you in the topic of the acute pulmonary embolism. Actually, it will be for 3 days. This is day 1, next week, day 2. By the end of August will be day 3. This week, we have our elegant speaker already, Dr. Adel Ahmed. He presented one of the most difficult, troublesome topics, which is the PE dilemmas in critical care settings. Then my presentation tonight will be a highlight about the guidelines. Next week, inshallah, we will have 3 elegant speakers. One about birth by Dr. Tharwat Isa from UK, and my close friend. Next lecture in the second day, it will be pharmacologic tidbits, but by our clinical, eminent critical care clinic pharmacist, Dr. Hassan Al-Toumi from King Abdullah Medical City. And the third will be about the interventional radiology management of acute PE by our eminent interventional radiology consultant, Dr. Muhammad Raslan, also from King Abdullah Medical City. Then we will end, inshallah ta'ala, by the last week in August, as if we have time, inshallah, we will have an interactive session, like an OSCE, just for our colleagues who are preparing themselves for the board, fellowship, or MD or master exams. Inshallah ta'ala, it's a matter of review what had presented over the last 5 lectures, inshallah ta'ala. So let's go quickly, because I think we are running out of time, and I hope inshallah ta'ala within the time frame given to me, I can cover this very tough topic, which is the guidelines for the diagnosis and management of acute pulmonary embolism. Why I'm saying tough, I think Dr. Adel Ahmed, the previous speaker, he presented very unique dilemmas, and he covered some of the evidence and recommendations. Though my topic tough, because just like I'm highlighting the guidelines, the recommendation, the classes, but I will try with some slides I will present it here just to make it less tough than I thought. So the guidelines of the acute PE, it's the latest that we have right now in our pocket, which is the European Society guideline published in 2019. Tonight I have nothing to disclose. Before proceeding to the guidelines, and actually when I am going to present any guidelines in the medicine or in critical care settings. I have those, I can call it some facts, or you may call it personal opinion. And by the way, in King Abdullah Medical City, for our fellows and resident board residency in critical care, we are conducting a yearly updated guidelines in the critical care settings, covering the medical, surgical, and the neurocritical care. Almost around 17 to 19 published clinical practice guidelines. And we just run the first one of this course just like 2-3 months ago. And this is one of the guidelines we presented in this course. And inshallah ta'ala, we are just planning to make it as a regular course, but unfortunately it's in physical attendance, not an online. Hopefully we can make it, inshallah ta'ala, a version of online for updating the guidelines. So just to tell you or to share with you some facts or personal opinion I'm mentioning always when I present one of those guidelines. Remember that guidelines are guidelines. What does it mean? It means that it guides you, and it's not a holy Bible. It guides you for the management, but remember, it's not a holy Bible. It's a guidelines. Second, all guidelines in medicine, not only in critical care settings, are not immune from the dynamic changes. Today, those guidelines, recommendation, and the class are with us. Tomorrow, they may leave, they may disappear, they may be obsolete. Third, remember, an intensivist or ER physician or anesthesiologist or in the OR or in internal medicine in the floor, or you are a member of the multidisciplinary team, you are a clinician. And again, you are at the bedside. So remember, you are the driver, and those guidelines are the passenger. Next, remember also, whenever a discrepancy or a conflict exists, use your clinical judgment, and this clinical judgment should take the precedence. Next, appreciate and admit the available resources and the expertise. And I think we taught the lesson from the COVID pandemic when we have limited resources. And I think on the chat, we have some questions about the gold standard in peripheral hospitals or remote areas. One of our eminent consultant, Dr. Ashraf, was asking about the availability of catheter-directed therapy or mechanical thrombectomy in Egypt. So this is a very important appreciation that you should know and admit what available resources you have, and who is expert in this field, you may refer to him, or who is the expert center if you do not have the proper intervention, recommended intervention. Do not wait. If the patient is stable and can be transferred, for his safety and for the sake of proper management, refer him to the best center that have the resources and the expertise. Next, you should remember also and practice what's called multidisciplinary management. And I consider this multidisciplinary management with different specialty is the best, with the best available clinical evidence or practice guideline in your hand. And this is much, much better than the one-man show. And I think Dr. Adel Ahmed, he highlighted about the PERT team or Pulmonary Embolism Response team, and Dr. Tharwat Isa, inshallah ta'ala, next week, he will present one of the most important multidisciplinary or an example of this multidisciplinary management, which is the PERT or a Pulmonary Embolism Response team. The same like sepsis code team, the same like code blue team, the same like rapid response team. And the last but not the least, remember those guidelines, sometimes they have gaps. and you should be aware about those gaps, because the gaps in the guideline still till the time I'm talking to you, those gaps are still existing. And those gaps, it means that it's not covering the whole case scenarios. And some recommendation is still personal opinion or some expertise opinion. It's not supported by randomized controlled trial or cohort study. So when you have gaps in the guidelines, this mandates again the clinical judgment bedside, as well as the multidisciplinary management, as we mentioned, for example, the Part T. So those you can make it like a fact, or consider it as personal opinion. You may agree with me, or you disagree. I respect both. So the guidelines tonight, as I mentioned, is the 2019 European Society guidelines. This is the latest that we have in our pocket now for the diagnosis and management of the acute PE. And it was developed in collaboration with the ERS, which is the European Respiratory Society. So it was a collaboration between the European Society of Cardiology and the European Respiratory Society. This is the link for anyone who can download this guideline. It's a very comprehensive guideline, very detailed, covering most of the topics related to the PE, to the acute PE, and even answer some of the questions regarding post-PE management, pulmonary hypertension, oral anticoagulant management. So through this link, it's a free download. You can Google it, and you can download the PDF version. This is regarding the guideline. So when I present the guideline for any topic in the critical care medicine, I should have a roadmap. So what's my roadmap tonight? First, what's the new in these guidelines I'm gonna present tonight? Next, what about some new definitions or the new concept definition? And I think Dr. Adel Ahmed, he mentioned those definitions regarding the low and the intermediate risk and high risk. So there is a new concept definitions. We will highlight it during my presentation. Then one of the guidelines roadmap, you have to know when you assess a patient with suspected PE, the predisposing factors. Then one of the important roadmaps covered by the guidelines is the diagnosis of acute PE, and either in tertiary care hospitals or quaternary or secondary or even remote hospital. You have to be aware about the predisposing factors and how can you reach a diagnosis of most likely or confirmed PE. Then one of your rules when you manage patient with acute PE is to assess how severe is this PE. So PE severity, it's a very important roadmap during managing patient with PE, because it will tell you how severe is this PE, what's the predicted complication at 30 days, what's the predicted mortality, and how can you outline the management for based on the PE severity. Then what about the treatment options available for patients presenting with acute phase or during the acute phase of PE, either patients who have comorbidities or pregnant patients or patient with cancer, patient without cancer, patients in the ER or in the floor, who needs ICU admissions, what the treatment options available during the acute phase, either for low risk or for intermediate risk or for high risk PE. Then we will highlight some gaps in the current evidence, as I mentioned to you that sorry.
What is the wrong, Dr. Adel?
I don't know. Maybe I went out of the meeting. I will go through.
You are in already. You are in.
Because the screen is not with me. Okay, so now I'm in, right?
Yes, you are in.
My screen is shared. Okay, thank you, Dr. Hussein. So the gaps, as I told you, the gaps is still existing even with the current guidelines. Then one of the good things in these guidelines, and I encourage everyone is reading these guidelines if he do not want to go through those pages or this comprehensive guidelines, and he wants to have some summary, or he doesn't have time while he's in the OR or sitting even in the ICU in the break time, he can have this 2 slides or 2 pages, what to do and what not to do. And this is the summary of my presentation or my guidelines. And if I will sum up, I can sum up with this title or with this pages or with those slides. What to do based on the class of recommendation evidence, and what not to do based on the class of recommendation and level of evidence. Then I will sum up with some key messages. What's new in this guidelines? There is a new or revised concepts regarding the diagnosis, the risk assessment, the treatment in the acute phase of PE, PE in pregnancy, and PE in cancer patients. And it covers the chronic treatment after the first 3 months. And this is, I think it was an area of questions for Dr. Adel. And the long-term sequelae also, it was an era of, it was a place for question for Dr. Adel also for RV dysfunction or pulmonary or pulmonary hypertension. When you go through any guidelines, you have to know about the grading system guideline. It's used for such guidelines. For our guideline that we have tonight, we have class or strength of recommendation, which is class 1, then class 2, then class 2 is classified into subclasses, class 2A or class 2B, then class 3. And this, each one of those classes, this is a class of recommendation. There is a definition and there is a color, and this is to make it just alerting. And this is one of the good things that when you read these guidelines, so you can be attracted also by the color ligand. So the current green, it's recommended or indicated. When you have this yellow, it should be considered. When you have orange, may be considered. When you have red, it's not recommended. And this based on an evidence-based derived from this grading system, either class 1 or class 2. So I will not go through, but just when someone is reading, before going directly for the core topic, please spend a few minutes with the grading system. Next is the class, because when you have the table, and it will come soon within the few minutes in the slides, you will find class A, level A, or level B. So there is a difference. You have to know the differences between the class of recommendation and the level of evidence. So the level of evidence is either level A or B or C. This is based on the randomized control trial. So this is for A, or if this data, for example, using catheter-directed therapy or mechanical thrombectomy or ECMO. So those data either derived from RCTs or from multiple, for A, or single RCT or non-randomized studies. This is for level B, or it just level C, which is the consensus opinion of experts, or just retrospective or registry studies. What's new? It's new regarding the diagnosis. What's new now in these guidelines for regarding the diagnosis, the updated the D-dimer use in the diagnosis. So the cutoff value not only the cutoff adjusted for the age and or the clinical probability. This is very important. So do not use the D-dimer alone, use the D-dimer in constellation of the age. So we call it age adjusted and clinical probability. Next, for the diagnosis is the updated information provided on the radiation dose when using the CT pulmonary angio and the lung scans. And this is important for our colleagues in the radiology service. What's next in the risk assessment? For risk assessment is very important, and a clear definition of hemodynamically instability and high risk PE. This is in this guideline was provided. What's the definition of hemodynamic instability and what's the definition of high risk patients? And this is very important when listening to one of our colleagues in the ER or in the floor. He's telling this patient is unstable. So when I'm doing the round with our residents or fellows, then I will ask him, please tell me what's the definition of hemodynamic instability. So it should be precise and clear. And this is what already happened or listed here in these guidelines. Next, in the risk assessment of assessing the PE severity and early PE related risk or complication. And this is very important when you manage patients with acute PE. Not only diagnosis, but you have to go for PE severity, and I will tell you later how we can do this. And related complications. This should be translated in the context of multiple comorbidities or any aggravated conditions other as the overall risk assessment or mortality assessment. And also, with what was new in this guideline was a clear word of caution that RV dysfunction, when we hear from our colleagues in who did the echo, or when you are familiar with focus or point of care ultrasound, and you will say that there is an RV dysfunction is present in your patient, it should be taken in caution because the management will differ completely based on your statement, which is RV dysfunction. And this will affect the early outcome if it's available, and it assess you or tell you that how you are assessing the patient severity with or without risk RV dysfunction. And treatment, what was new regarding the treatment, now we are moving from diagnosis, risk assessment to treatment in the acute phase. What was new in these guidelines? There was a comprehensive revision on the hemodynamic and respiratory support in high-risk patients, or the previously called or labeled as massive PE. There was a dedicated algorithm or management algorithm for a high-risk patient because those carries the high risk of mortality. And high risk is previously known as massive PE. Regarding NaNOAC or non-vitamin K oral anticoagulants, the recommended in these guidelines as one of the first choice anticoagulant in patients who are eligible, here be cautious, who are eligible for receiving NOAC. And Dr. Hassan Toumi, inshallah ta'ala, our eminent clinical pharmacist from King Abdullah, next week, Medical City, he will present the pharmacologic tidbits in acute Pe, and this is one of the important topics. Next, what's the risk adjustment management algorithm was revised, and it took into consideration the PE severity and clinical backgrounds, the underlying comorbidities, and any aggravated condition like pulmonary hypertension or tricuspid regurg or volume depletion or a patient with hypercoagulable state. So it should be taken in consideration. Moreover, those with special scenarios or dilemmas that Dr. Adel Ahmed already presented, as well as the presence or absence of RV dysfunction. Also, what is new in these guidelines, what the important highlight about the terminology. So if you remember, most of our colleagues in the ER or in the pulmonology service, they use or internal medicine, they use provoked and unprovoked PE. So now this terminology, provoked or unprovoked of PE or VTE, is no longer supported by this guideline. So this guidelines is not using anymore the term provoked or unprovoked. Why? Because it's misleading, and this is what we are till yesterday we are hearing from our colleagues who are not aware about the guidelines or the updates, that they are still using the provoked and unprovoked. And why it's misleading? Because it's not helpful for decision making regarding the duration of antibiotics. of anticoagulants. Sorry, I'm fascinated with antibiotics, so I apologize. So this is the something new. So please do not use the term provoked and unprovoked for the reason that I explained. What's new here? Dr. Adel already presented the PE in pregnancy, and also the PE in cancer or malignant patients regarding the anticoagulation, the use of enoxaparin, and the use of NOAC. There was some change in the recommendation from the previous guidelines. Yes, there was one on 2014, and there was one also in 2016, but the one was the stock, and they compare over the 5 years from 2014 to 2019. There was a change in the recommendation regarding the rescue thrombolytic therapy when a patient deteriorates in hemodynamic wise. There was a difference in the indication of either surgical embolectomy or catheter directed. There was a change in the class of recommendation regarding the diagnosis and the use of the dimer, and I told you regarding the clinical prediction rules or scores, and also for further evaluation of asymptomatic PE survivors who are at risk of pulmonary hypertension. So here is the evidence. If you can look carefully for the slides and the color, here is how they have been changed from 2014, and the evidence transition from 2 to 1 to A to 1 to B to 2A to B to 2A, and here was not recommended. Here is class 2P, and so on. What about the predisposing factors? Yes, all of us, we know that knowing in advance the predisposing factor for PE is vital and important to determine the clinical probability, and this increased the number of predisposing factors, of course. Remember that about 40% of patients with PE, interestingly, they don't have predisposing factors. Although hypoxemia also is a frequent presentation in acute PE, but they reported close to 40% of patients have a saturation and 20% they have a normal AA gradient. So this is very important to know that those predisposing factor is very important to know, because almost 40% of them didn't have predisposing factor, and the 20% of them they have AA gradient, 40% they have normal oxygen saturation. Those are the known or well-known clinical risk factors, either strong risk factors or moderate risk factor based on the odds ratio, or weak risk factors. So you have to appreciate the strong and moderate, and to look carefully also for the weak risk factor, but do not ignore. Now, for people who likes the scores, and Dr. Adel Ahmed, he already mentioned some of those scores. So we have clinical scores or criteria for PE when you are facing patients with suspected PE. So first of those scores is the PERC, or we call it pulmonary embolism rule out criteria to rule out PE. This PERC should be used carefully because it rules out the PE if there is no criteria are present and if the pre-test probability is less than 15%. So this is what we call it PERC. It rules out. So this criteria should be used carefully, because this criteria or this score, it rules out but does not rule in. And here I put just a link. I will use it in this slide, but with the rest of score, just I will give you an example. Here, you don't need to memorize what's the components of the score, but you have to be aware about it. But it's very easy now because all of us now, we have smartphones and we have apps. So one of the important apps for the intensivist and for anesthesiologists, ER physicians, you have to have the MidCalc app. This is how, just I will give you only one example. So this is how can I use the MidCalc, very comprehensive score, not only giving you the number or computing you the risk. Here is the example. I open here the link for PERC. So here PERC rule for pulmonary embolism. Very nice. Before going to calculate or to compute, please go for those 3 important items. When to use this score, any score, even glaucoma score, SOFA score, whatever the score you use, Wells score, PES score, whatever. So when to use this one. So you have to have an idea, and this is very nice in this application. Then what are the pearls and the pitfalls? It's very important. Then when to use this score. So when you are aware about this score regarding when to use, why to use, what are the pearls and the pitfalls, then you can use here the criteria, and it give you immediately based on this criteria. For example, for patient, if he's having 0 on PERC, so they call 0 criteria and no need for further workup, less than 2% chance of PE. And these are the items of the PERC: age more than 50, heart rate more than 100, equal more than 100, extratracheal or room air less than 95, unilateral lower extremity edema or swelling, history of hemoptysis, recurrent surgery, history of recent surgery or trauma for less than 4 weeks. So based on these items, you give the score. And for example, here you can look for PERC. Now, for my patient, if I will give him, he came with respiratory distress, and I give him 1, the age of more than 50. So by 1, if any criteria is positive, the PERC rule cannot use to rule out here. But if it's 0, it's a God negative to rule out the PERC, to rule out the PE. So this is how I can use this score, and just I will move to the next. Next is the one of the common scores that we use it for PE is the so-called Wells score, and I think most of us are aware about Wells score. Again, you do not need to memorize what the components, but because MidCalc will make your life easy for this. But you should know about the following. What's the rule of this score so you can use it? Like I told you about the PERC. For Wells score, it objectifies the risk of PE. Here is very important because it objectifies the risk. Here is the link as I showed you on PERC. So you go and go to the MidCalc, read when to use, why to use, what are the pearls and the pitfalls. Because each score of these, it's at the end, it's a clinical score. It's not a lab. So it's not 100% sensitive, not 100% specific. So based on the Wells score, we have either what we call it risk stratification 3 level, or the traditional Wells score assessment, or the modified Wells score at 2-tiered or 2 levels. Those are the components of the scores. 3, those are 7 items. This is the score and the points. Then you drive and you calculate. Based on those calculations, you may have the modified risk. So either less or equal to 4. So the PE is unlikely, or more than 4 is likely. Or you are using the so-called the 3-level or the 3-tiered score, either low risk if the points or the score less than 2, moderate risk between 2 to 6, or high risk more than 6. And remember, this score of stratification of likely or unlikely. So based on the 3-tier model, you may go for further workup or for further investigation. So for less than 4, you will consider D-dimer. If the D-dimer is negative, you will consider stopping further workup. If between 2 to 6, you will, it's a moderate risk. So you will, sorry, see here it's my mistake, is less than 2, not less than 4. I apologize. So if less than 2, you will consider the D-dimer. If between 2 to 6, you will consider the age-adjusted and the high sensitivity D-dimer, or images according to the patient situation, with renal failure or without renal failure, pregnant or not pregnant. So you can use CT pulmonary angio or VQ scan. Third, if the Wells score more than 6, here you will go for either CT pulmonary angio or we call it B study, or VQ scan, as mentioned earlier, based on the renal function or pregnancy status. Another score, so now we have PERC, we have Wells score, we have the revised Geneva clinical prediction rule. This is again clinical prediction rule. If you remember, there is no lapse in those scores requested. So based on clinical data, age, saturation, hemoptysis, history, surgery, trauma, and so on, tachycardia. So another score is called revised Geneva clinical prediction rule for PE. Also, it objectivize or assess the risk of PE like Wells score. Again, I will not go through this. Sorry, so this is guideline. Sorry, this score. And this revised Geneva score is again assessing the risk assessment of PE, and it's considered as a clinical prediction rule. Here we have the original Geneva score, and we have what's called revised Geneva score, just minimizing the number of items. And these are the clinical probability, like Wells score, either 3-level score, low, intermediate, or high, based on the numbers, or 2-level, BE likely or unlikely. And remember, regardless the score you use, whether Wells, whether Geneva, the proportion of confirmed PE can be expected. So this is what I'm telling about the sensitivity and the specificity. So no one of those scores is 100% sensitive, 100% specific. So regardless the score you use, still you have, when you, for example, still you have your clinical sense or clinical judgment, and you ignore one of those recommendation of the scores as a moderate probability or be likely, unlikely, and you went for more standard or gold standard like CT pulmonary angio or one of the VQ scans, you will find that still there is a confirmed PE of about 10% in low probability, 3% in medium probability, and 65% in high probability. When the 2-level classification or the 2-tiered classification is used, the proportion of about 12% in the unlikely PE and 30% in the likely PE. So this is put in your mind whenever you use the revised Geneva or Wells score. So this is a very important statement. And these are the guideline recommendations for the diagnosis of PE. The diagnosis here is classified into PE with hemodynamic instability and PE without hemodynamic instability, and moving to the clinical probability or clinical prediction score or clinical recommendation. And here the highlight in high-risk patients with hemodynamic instability, you cannot move the patients. So bedside echo has a rule, and here in green, you remember class C, level of evidence C. and of your patient can be transferred. So emergency CT pulmonary angio, depending on the availability and the clinical circumstances and the renal function. And regarding also, as Dr. Adel said, when you have suspected or high index of suspicion of index of suspicion of PE, so you start the anticoagulation until the therapeutic, until you, without delay, of course, until you confirm rule in or rule out. Also regarding the D-dimer, so the D-dimer used, you should ask your lab, because your lab should use what's called high sensitivity assay, and this is recommended even for ER patients or ICU patients when you diagnose or you take into consideration the D-dimer plus the cut value and the age adjusted. So as you adjust, for example, the calcium for albumin, so we call it corrected calcium or anion gap for albumin. We have our QTC interval for heart rate. We have to adjust the D-dimer cutoff according to the age, and this is the equation how to use it. And this is not your job; it's your lab job. This is the recommendation for or the guideline recommendation regarding the CT pulmonary angio. And this is one of the gold standard tests or imaging technique that we use it for confirming ruling in or ruling out the PE. And this is the class recommendations. How can you use it when you have a high index of suspicion or clinical scoring? And I will show you, this is the level of evidence and the class of recommendation, but this is very important regarding the CT pulmonary angio. It's the gold standard. It will tell you not only the phallic defects or sudden embolus, but it most importantly, with ruling in or ruling out, it will tell you the RV to LV ratio. And this is one of the good data that we can derive from CT pulmonary angio. So if you request a CT pulmonary angio, please ask the radiologist not only to comment on the pulmonary tree and phallic defect, ask him to comment on RV, LV size. For CT pulmonary angio, you have to remember that according to the BioBed 2 study, they observed a sensitivity of about 83% and specificity of 96%. So still for the sensitivity, still we have false positive, like when you have an artifact or something is not like a venous thrombi. So it's again, it's not 100%, but it's a good test with high specificity to rule out. Regarding the VQ scan, it's also have a rule of recommendation, and one of the gut tests when the scan or the lung perfusion scan is normal. So when you requested in a proper indication with acute renal failure or contrast allergy or during pregnancy, so if you have the perfusion phase is normal, so this is a good rejection test, you can go without further testing. And this is how important to decide on using the VQ scan. You can use it in pregnancy, as I mentioned, in patient with history of contrast anaphylaxis, or patient with severe renal failure, or ER at risk of contrast-induced nephropathy. Now moving to the guidelines regarding the echo or the use of transthoracic echo, and I think most of us is familiar now, either cardiologists or non-cardiologists, intensivists who are using BOCUS, they are familiar at least with bedside echo. So remember, with the use of transthoracic echo in the diagnosis of PE, the negative predictive value is about 40 to 50%. The negative results or the negative echo cannot exclude PE. Still is not the gold standard, but it will help you to stratify and to guide you what's the next image or diagnostic tool you would like to do. Or when your patient is unstable or you cannot move him, is on 100% of IO2, intubated, 3 or 4 vasopressors, a post-cardiac arrest. So this is very important. And signs of RV overload or dysfunction also can be found in the absence of acute PE. So this is one of the fallacies, especially if you have concomitant cardiac or respiratory diseases like patient with COPD, core pulmonary, severe tricuspid regurg, volume overload. So those are confounding factors that may confuse you, or thromboembolic, chronic thromboembolic pulmonary hypertension. Just I will move quickly because of the time. Remember that RV dilatation is found in more than 25% in patients with PE when you do transthoracic echo, and this is a very useful for risk stratification of PE. But remember, if you are familiar, and this is important for people who are familiar with echocardiography and PE patients, if you have combination of Mcconnell sign and the 60/60 sign, this combination, it's important to tell you this is a good sign of RV dysfunction or RV strain. So Mcconnell sign is important for delineation, not alone. Still, it has its own sensitivity and specificity reduction, but remember also those findings, which is the Mcconnell sign and the 60/60, it reported, they are reported between 12 to 20% in acute PE patients, and increase with the incidence, increase with the severity of the PE. And this is for people who are aware about the Mcconnell sign. So the Mcconnell sign is characterized or a sign of severe hypokinesia or dyskinesia of the mid right ventricular free wall, sparing the apex. You will find the apex is contracting well, but the right free wall is severely hypokinetic or dyskinetic or even akinetic. So this is one of the studies they tested, was an old study in the 90s. They tested the sensitivity of 77 and a positive predictive value of 71%. Also for RV infarction, Mcconnell sign was found to be in about 67%. So you have to be interpreted cautiously, not alone, but with others like RV dilatation, like S66 sign. If you have deviated septum, severe RV dilatation, D shape of the intraventricular septum, mobile thrombi in the right atrium or right ventricle. So those are important clues that will tell you that there is an evidence of acute RV strain or acute RV dysfunction. Role of ultrasound for assessing the source, either DVT and upper or lower extremities. Commonly, the PE originates from DVT and lower extremity, but rarely from upper limbs, but it can happen. This is regarding the recommendations. And remember, for the pathophysiology of PE as a source of increased RV afterload and obstructive shock, this is with increase in the RV dilatation, the tricuspid regurg, RV dysfunction, and RV ischemia, decreased contractility. This circle would end up by decreasing the LV load, the hypotension, decreasing the coronary perfusion, and end up by cardiogenic shock and mortality. So your role here for this model of a spiral death is to intervene as fast as you can and to lower the risk of complication by assessing the risk, by choosing the appropriate intervention. Here is the new classification of the acute PE. As I mentioned, we are not using now massive and submassive like before in the previous guidelines. We have 3 types or 3 classes of PE based on first hemodynamic status, and second is the presence of or absence of RV dysfunction with echo or with CT pulmonary angio. Second is the biomarkers, which is the troponin. You add to this is the pulmonary embolism severity index class. This is a third important, but most importantly is the hemodynamics, the RV dysfunction, evidence of RV dysfunction, and biomarkers. If a patient is having hemodynamic instability, evidence of RV dysfunction by echo and pulmonary angio, elevated troponin, this is what we call a high risk PE. Add to this, you calculate what's called pulmonary embolism severity index score. So this is called as high risk, previously called as massive PE. Now we are not using the term of massive, we are using high risk PE. Now the second entity or the second class is called intermediate risk. Intermediate risk is subclassified to either intermediate high or intermediate low. What's the difference between intermediate high and intermediate low? The intermediate risk differs from the high risk with the hemodynamic stability. For hemodynamics, it's stable. The patient is hemodynamically stable. But if intermediate high, if you have evidence of RD dysfunction and troponin leak is high, and the pulmonary embolism simplified score more or equal to 1, so you have 3 indicators that this is intermediate high. While the difference from high to low in the intermediate risk is that, again, the patient is hemodynamically stable, but he has either or. He has either RV dysfunction or elevated troponin, not both, but he has a simplified pulmonary score equal or more than 1. While the low risk PE is hemodynamically stable, pulmonary embolism severity index, the simplified, is less than 1. There is no RV dysfunction, or the patient may have some troponin leak, so it's not considered in this. So this is, we call it low risk. So this patient can be managed on outpatient basis, intermediate low risk, based on the clinical scenario, based on the comorbidities. It can be managed in the floor or in OPD patients, but both patients, high risk and intermediate high risk, should be managed in the ICU because they are at further deterioration. And here is the evidence of or definition of RD dysfunction. One of the indicators is the most important indicator. You got it from the echo or from the CT angio, is the ratio between the RV size to LV size. As far as the RV to LV size, more than 1, equal or more than 1. So this is an important, this is as a more important indicator of RV dysfunction. Or if you have TAPSI, which is the tricuspid annular plane systolic execution index 16, this is most frequently reported as evidence of RV dysfunction. This is the definition what I am telling you regarding the hemodynamic instability. You have 3 classes. If the patient had persistent hypotension, what does it mean, persistent hypotension? Less than 90 systolic, or drop by or equal to 40 from his baseline and lasting for more than 15 minutes, not caused by other sources like sepsis or hypovolemia or arrhythmias. This is what we call it persistent hypotension, and this is a sign of hemodynamic instability, putting the patient under the category of high risk PE. Second category is the obstructive shock, and this is the definition of shock. If you have persistent hypotension, systolic blood pressure less than 90, or patient required vasopressors to achieve the target systolic more or equal to 90, despite you give optimum fluid resuscitation with end organ damage like hyperlactatemia, altered mental status, or oliguria. So this is the second entity of hemodynamic stability, which is the obstructive shock. The third, which we call a devastating PE, which is the PE in the scenario of cardiac arrest. Highly suspected or confirmed PE, then the patient develop cardiac arrest, and this needs for urgent cardiopulmonary resuscitation. You may go for modified thrombolytic therapy plus minus VA ECMO. I think because of the time, sake of the time, I may end here because now I completed almost 55 minutes. So I may just conclude quickly, and if we have time, inshallah ta'ala, next session or the session of the OSCE, we can present further regarding the algorithms, regarding most of the topics related to the management. So just remember here, we are not using now massive and submassive. It's already out of the playground. Now we are using high risk, which is massive, or intermediate high or intermediate low dose for submassive. And here the management is different. So this is we are using now high risk, intermediate high, intermediate low, or low risk P. These are the classes, the three classes, and we are not using now anymore massive or submassive, provoked or unprovoked. I will go quickly tonight because of the time sake, because the core of my lecture still can be classified, can be divided into two types. Inshallah ta'ala, I promise next time I will, I can present the remaining of my presentation. So just to remind you about the gaps, as I told you, there is still gaps in the current evidence. The gaps is regarding the diagnosis, gaps in the assessment of the PE severity and risk of early death, gaps in the treatment of acute phase, gaps in the PE and pregnancy. And those gaps regarding the optimal method to adjust the D-dimer threshold cut off to include or to exclude the diagnostic value and the clinical significance of, as Dr. Adel mentioned in his scenario, isolated subsegmental PE, and this we found incidental finding when we do CT angio, for example, for anything else rather than PE, and the triple rule out approach. Also regarding the assessment of PE severity and the risk of mortality, about the optimum clinical and most relevant combination and the cutoff of the clinical plus the biomarkers, if we are using troponin, PMP, and the clinical prediction score. Also assessing the RV status in addition to the clinical parameters you have to classify your patient, either symptomatic or asymptomatic, acute, low, or intermediate risk PE. Moreover, is the treatment in the acute phase, and those treatment we have sharp or clear recommendation, for example, regarding the high risk PE, like thrombolysis, or catheter directed, or surgical embolectomy, or mechanical thrombectomy, plus the anticoagulation. But there is certain gray zones, which is the intermediate high risk, is to thrombolyze systemically, either the full dose or reduced dose, or to go for catheter directed and mechanical thrombectomy. And I think this is still a gray zone, and one of the gaps we don't have randomized control trial yet. Dr. Muhammad Raslan, as interventional radiology, he will present his vision and his recommendation and his experience with us from King Abdullah Medical City, and also Dr. Hassan Toomey, he will also share the pharmacologic recommendation regarding the full or reduced dose of TPA. Dr. Adel already he passed through the PE and pregnancy. This is what I told you what to do and what not to do if you would like to come out with a summary of these guidelines. So here in green, this is the class and what to do. Red is class 3, not to do. There is what to do regarding the diagnosis. So please, I refer you to go through regarding the risk assessment, regarding the treatment phase, an acute phase, regarding the chronic treatment and prevention of recurrence and duration of anticoagulation, type of anticoagulation, which you prefer even in the acute phase, unfractionated or low molecular weight heparin, NOAC, or vitamin K anticoagulants, regarding the management of pregnancy, regarding the diagnosis, and also post-PA care and long-term sequelae. This is what to do and what not to do. So again, I'm encouraging everyone, he's exposed to these guidelines and he wants to know about these guidelines, just to have this summary in his pocket. And at the end, I have to sum up and conclude with some key messages. But remember, still in my lecture and presentation, still there's a core regarding the severity assessment index, regarding the management. I may, inshallah ta'ala, if we have time, just I went quickly just to save your time for key messages or take-home messages for bedside.
Few minutes.
Okay, so for bedside transthoracic echo in patients presenting with hemodynamic instability, you should be familiar and aware to perform the bedside echo assessment as fast as immediate, because it will differentiate a suspected high-risk PE from other life-threatening situation when you manage patients with undifferentiated shock. So you have to be familiar. So from now, if you are not familiar, you have to have a skills and experience, because it may make your life easy. You will not wait for the cardiology to come. It will take time. It can differentiate even in the ER, and it will tell you what's the proper management, especially if you are managing patient with undifferentiated shock. What about the anticoagulation therapy? If you suspect acute PE with clinical prediction score, most likely, or moderate or high score, so start, as we mentioned earlier, the anticoagulation as soon as possible, while your diagnostic workup in parallel is going on, unless the patient is having absolute contraindication for anticoagulation or has a high risk of bleeding. You have to have in your pocket a clear, precise diagnostic algorithm for patient who's hemodynamically stable or unstable, pregnant patients. So those are algorithms that highly recommended. Use it when it's validated, or you have your own protocol based on available evidence or protocol in your hospital. Regarding the single subsegmental PE, if the CT pulmonary angio reported that there is a single subsegmental PE, consider the possibility, as we told you earlier, that of false positive finding. And you have to pick up the phone, discuss this finding again. Do not take it for granted, and discuss it with the oncoradiologist, or you can take second opinion. Why? To avoid the misdiagnosis, unnecessary, maybe harmful or potentially harmful anticoagulation, especially if the patient is coagulopathic, thrombocytopenic, bleeding diathesis, or recent post-operative. For risk assessment, confirming the PE or confirmation of PE in patient who is hemodynamically stable, it should must be followed by what's the further risk assessment. And this risk assessment is very important. First, as we mentioned, you are a clinician. So what are the clinical findings? What's the size and the function of the RV by echo or by CT pulmonary angio if you have the data available, RV to LV ratio, and use in your hand the available biomarker that you have, like troponin or BMP, or we have recent now what's called heart affinity, one of the amino acids biomarkers. It will decide about the need of reperfusion treatment or catheter directed or admission to the ICU or admission to the ward, or this patient is a low risk PE, can be managed on OBD scenarios or ABD status. What about the best reperfusion option? As soon as you diagnose or highly suspected or strongly suspect high risk PE, you select the best reperfusion option in your hand, in your facility. Systemic thrombolysis, catheter directed if you have expertise and available resources, surgical embolectomy if there is absolute contraindication for systemic thrombolysis, or no available or contraindication or thrombolysis related complication, or the absence of interventional ideology around. So you may decide here with the multidisciplinary approach using the per team, which is the best reperfusion option, and it should be documented. This is considering the patient risk profile, resources, and expertise available, as we mentioned. Regarding the intermediate high risk, BE is still one of the gray zones for using the best modality. Reperfusion therapy is considered not the first line of treatment, and I mean reperfusion therapy is the TPA or streptokinase in some instances, because still in some hospitals or peripheral hospitals, they don't have, for some logistics or cost-wise, they don't have this RTPA and they have streptokinase. Dr. Hassan, again, he will highlight about the role of streptokinase use and PA. So again, in intermediate high risk, the reperfusion therapy is not the first line, but you should prospectively or preemptively plan with your per team to have a plan ready with you if this patient deteriorated. You started him on heparin infusion or low molecular weight heparin, but the patient is not improving, requiring oxygen support higher than before, hemodynamically became unstable. So you prepare this in your bucket, a reperfusion therapy, either with systemic thrombolysis or catheter directed. Be in pregnancy, you should consider the diagnostic pathways and algorithm for pregnant patient, including when to use the CT pulmonary angio, or the preferentially is the VQ lung scan, as well as what's the management protocol optimum for this patient, and you can use it safely during pregnancy to save the mother and the fetus. Regarding the oral anticoagulation after the acute phase, this is an area also will be covered regarding the NWAC over the traditional of vitamin K antagonist regimen. Also, the risk assessment for recurrence after the first episode of PE after 3 to 6 months of the anticoagulation. It's also not the intensive stroll, but this is mostly for VTE team or pulmonary service team who following up this patient after discharge from the hospital. Thank you, and I apologize for exceeding my time. Almost I spent 1 hour, but it's my great pleasure and honor, and I have to thank you again. Thank you.
Hussein is here. He should be here.
Sam, you are muted.
Most sorry.
Thank you, Dr. Adel, for your fruitful presentation. I think it's a hard mission to cover those sophisticated guidelines in one session, and thank you for simplifying these issues. And that's why I think it's gonna be spreaded over 3 sessions. It's a very big topic and should be covered from all aspects. I have just a couple of questions before ending, because there is one question missing from the first lecture. When to use low molecular weight heparin and when to use new oral anticoagulants in pulmonary embolism?
So I can leave it for Dr. Adel or Dr. Hassan or Dr. Adel. تفضل. I will give the opportunity for Dr. Adel. تفضل.
As regarding the patient, if he has presented with high risk or intermediate high risk, we prefer unfractionated heparin, because at any time we will giving a thrombolysis, we will hold the heparin infusion and give thrombolysis and resume as early as possible. Okay. As regarding intermediate low risk and low risk patients, low molecular weight heparin is advised for patient with active malignancy. If patient has active malignancy and has PE, the recommendation is low molecular weight heparin, and this recommendation has recently changed. And currently, you are giving now like NWAC for this patient, like apixaban and levodoxaban for this patient. but it is preferred to give acutely if the patient is inpatient, low molecular weight heparin, and we send for routine lab for him, especially renal profile. And some patients who have high risk of bleeding, we prefer also low molecular weight heparin, because if the bleeding happened with NOAC, it is difficult to reverse, because all hospitals haven't the reversal agent for NOAC. But for patient who is young, no comorbidity, even active malignancy and low risk of bleeding, we can give him NOAC if he has low risk, and certain patient with intermediate low risk.
Okay, thank you, Dr. Adel. Dr. Nagi Negm has another question, 3 questions, but sorry, Dr. Nagi, I will choose 1 question from them only because of the time. What is the role of lactate level follow-up for pulmonary embolism? Dr. Adel Hussein. Dr. Adel Hussein.
So just before I will answer this. Regarding the oral anticoagulants and the type of all anticoagulants, not only NOAC or vitamin K antagonist, starting even from which is preferable, low molecular weight heparin or unfractionated heparin in the acute phase and post discharge from ICU or prior to discharge from the hospital and on long-term management. This is a very important era, I think. Being as an intensivist, we should aware about the low molecular weight heparin and unfractionated heparin, known to use which is the better. Till now, the guidelines stating that the low molecular weight heparin, if there is no contraindication and there is no acute kidney injury, creatinine clearance more than 30, so the recommendation is toward using the low molecular weight heparin. As Dr. Adel said, again, it depends on your settings, because for low molecular weight heparin, if you need to monitor the efficacy of your dose, if you are giving 1 milligram per kg Q12 hours, for example, if you have a guy obese like me, you are giving him 100 BID, so you have to monitor the anti-factor 10 activity assay. And this assay is not available in many hospitals, so you should be aware about this. So do not throw just enoxaparin or low molecular heparin, but you don't have a modality to monitor your efficacy. Or if you have a heparin resistance, for example, or your patient, as Dr. Adel said, if you have a bleeding catastrophe related to this enoxaparin and you don't have the antidote available in your institution, so you should be aware about this. If you will tell me I will not use and I will use unfractionated heparin, I will not tell you it's you're wrong. You are not absolutely wrong. You are right. You have some rationale, but again, this is not the best available evidence. But again, you are the clinician. You are aware about the scenario in your institution better than me. Because of, for example, if you stuck with overdose of enoxaparin and you cannot, you will be partially reversing with protamine, but the patient is still not fully reversed. So again, you are in trouble. And sometimes, especially if the patient is going for the OR for mechanical thrombectomy, or for surgical embolectomy, if it's not improving. Also, one more is regarding the assay, which is the anti-factor 10 activity. For unfractionated, we are familiar that we are using the PTT, but this is not valid for molecular weight heparin. So again, if you will tell me I will use unfractionated heparin, okay, but be aware about the scenario and the circumstances. The same when you use antibiotics and you are aware about antibiogram in your unit. So you may have prevalence or outbreak different than my hospital. Regarding the oral anticoagulant and overlap and the adjustment, and I think also Dr. Hassan, Dr. Adel, he already answered, and Dr. Hassan told me, because this is his era, and he's an eminent critical care clinical pharmacist, and in his presentation, he will give a very nice tidbits regarding this topic. Moving now, sorry for my lengthy comment, and I will move for the answer of lactate. Now, the lactate, as if I understood well, the question is a monitoring tool. Here we use the lactate, as Dr. Adel mentioned, for acute RV dysfunction and hypoperfusion state or hemodynamic instability. Here, if it is available, it's not a mandatory tool. I will not ask you unless the patient is having a signs of hypoperfusion, and it will tell you initially in the diagnosis as a sign of hypoperfusion. Plus, it will monitor the efficacy of your therapy. When you progress, giving, for example, you started with cardiogenic shock or post CPR or hemodynamic instability, and the lactate was 7-8. Then you start to thrombolize and you stabilize the patient, then your lactate is coming down. So for sure, you have to monitor the lactate because it will tell you. But this is not the one of the mandatory tests included in the diagnosis, but it's an aiding data when you assess the reperfusion and the response to your treatment. And of course, if there is a risk stratification, if your patient is deteriorating, have devastating PE, and his lactate is tremendously high, so this is one of the poor signs. And they found not only in obstructive shock and patient with undifferentiated shock with tremendous trending up of lactate, this is a very poor sign of unfavorable outcome.
Thank you, Dr. Adel. Unfortunately, time is up. I wish to stay more with you, but you know the time limit. Thank you for our great speakers tonight, Dr. Adel Hussein, Dr. Adel Hamada. Thank you for your nice presentation. Actually, you covered a lot of aspects regarding this hot topic, and we will wait for the next two sessions to cover the rest of this topic. If we have another question, sorry, we cannot do it now. We can reserve it to the next two sessions. Thank you very much for our attendees. Thank you. It was actually a great day tonight. Hopefully see you again and again. Thank you all, and we have to finish now.
Thank you, Dr. Wissam. Thanks a lot. It's our pleasure, and we are very glad that we have you with us as moderator tonight. And I think Dr. Saab, he was lucky that he gave us Dr. Wissam tonight as a moderator, and we wish you, inshallah ta'ala, for if we have next meeting to be with us. Shukran, Dr. Adel. Dr. Saab.
Thank you. Thank you so much.
Final word from our co-founder.
Thank you so much. We are so delighted and so grateful to you and your contribution, and especially to our colleagues who are appealing to the board exam in intensive care. From my side here, and I am so grateful to everybody here tonight. Thank you.
Thanks a lot. Thank you. And thanks for the panelist members with us, and we see you inshallah next week. Shukran, Dr. Saab. Shukran, Wissam. Shukran, Dr. Adel.
Thank you, Dr. Adel. Thank you, Dr. Adel. Assalamu alaikum.